I will be summarizing to you what happened in the hem-onc session. The participants, as you can see, are here outlined on the slide. The background for the hem-onc session is the fact that along with the FDA, the EMA has put out a warning about the use of ESAs in our field in the curative setting. The wording is slightly different between the warning of the FDA and the warning of the EMA. The EMA is a little bit more flexible in the sense that the warning is that we should use them with caution, whereas they should not be used, according to the FDA, in the curative setting in the hem-onc patients. So first of all, Dr. Delarue showed to us the data of the French study in a curative setting, which is non-Hodgkin's lymphoma, high-grade B non-Hodgkin's lymphoma. He also reminded us that we also have had the data from the German group with Hodgkin's lymphoma, which shows no negative effect whatsoever of the addition of epoetin to chemotherapy in that curative setting. There is a slight decrease in numbers of transfusions. There's no difference, none whatsoever. And for those that like to look at the curves in the German study are slightly above for those who receive EPO compared to those who don't receive EPO in terms of survival. As you can see, for progression-free survival in the French lymphoma study, patients receiving an ESA, in this case darbepoetin, do have a better progression-free survival. This is statistically significant with p-value 0.04. However, there's no difference whatsoever in terms of survival. So we had some discussion about all of this, and Heinz Ludwig said, oh, this is back to the 90s, wonderful. In the 90s, we had some enthusiasm because of cell studies, one of them being that of Tim Littlewood, that showed that there could be potentially a benefit in terms of tumor control in patients receiving epoetins. And then we have had all the negative signals and all the discussions. We asked Dr. Delarue whether he could explain to us why do we observe this difference in progression-free survival a certain time after the patients are not receiving anything anymore. For the time being, he's trying to analyze the data to see if he finds an explanation. There's no explanation whatsoever. What is clear from his data, what is clear from all the data in the hem-onc setting is that there is an increase in thromboembolic events. A discussion about the French data was that maybe the hemoglobin that we were aiming at, as the study had been designed in the early 2000s when we didn't have the conviction we have today for good or bad reasons that we should not aim to hemoglobin levels above 12, 13 max. In his study, there were a few percentage patients that were clearly above 14 and a few rare clearly above 15. And he said that there was indeed a correlation between the higher hemoglobin levels and the incidence of thromboembolic events. In terms of clinical practice, do these data indicate that there should be a use of ESAs? The numbers of patients being transfused in the study was slightly different in favor of the use of ESAs, as I will come back to this very soon. But overall, he told us that in France, where the study was done, ESA use with chemotherapy, I didn't push this, was something that was not a routine. One question asked about the difference in progression-free survival was, did the EPO arm, for some reason, allow for keeping the dose in time and giving the appropriate dose or not? The amount of chemotherapy, the way chemotherapy was given between the two arms was exactly the same. So that's not the explanation for the observation. It was suggested, and we'll come to the discussion about the positive or negative effects of transfusions we've done at SPAN, that the fact that there was less transfusions in the arm receiving darbepoetin, there was 34% of patients received one transfusion or more, versus 43% one transfusion or more in the no darbepoetin arm, could be the reason why there's a better outcome at the end. This is a speculation we had. What we don't know is in those that had no darbepoetin and had in 43% of the case transfusions, how many transfusions they actually had. In the curative setting, again, in the setting of neoadjuvant chemotherapy for breast cancer, chemotherapy which is given before surgery, there has been a study published by Michael Unch in the Journal of Clinical, in Annals of Oncology, which has shown, as you can see here, that this curve here, which is above this one here, is the curve of patients without double pointing. Overall survival, this one here, above this one here, is without double pointing. The statistical significance is non-existent. It's 0.06, 0.13. In spite of the fact of this being not significant, this is retained as a quote-unquote signal stating that there could be a problem in giving chemotherapy along, double pointing along with chemotherapy when there is a big tumor. Hello, Ian? You made it. In breast cancer. But we had another study that we discussed, which is the study of Dr. Möbus. This is a study also from the German group in the setting of adjuvant treatment for breast cancer, i.e. the breast has been operated and we are fighting against microscopic disease. In that setting, we don't have the final data yet. We only have presentations at meetings and a sentence in the publication about those chemotherapies stating that there's no difference in terms of survival, progression-free or overall survival with dabigatran or not. So we are left in a situation in which, in the setting of breast cancer curative treatments, some will take this as, yes, we could give dabigatran or epoetin alpha or epoetin beta or one of the biosimilars or not, depending on the clinical situation of the patient. Then we had a final presentation from myself on the Blömer study. This is a study in cervical cancer. Patients received 4 cycles of chemotherapy before definitive radiation for the cervical cancer, with or without the use of epoetin. In the arm where the chemotherapy was given with epoetin, the progression-free survival, the relapse-free survival, is at 0.06, statistically not significant, slightly better in those who receive epoetin. So there's no negative signal. So we have 3 settings of curative data, of curative treatments, which don't tell us that we should not be giving epoetin. And we have one where there's a question mark, and this is the neoadjuvant setting in the Möbus study. So in the clinical practice setting, what does this tell us? That there is a risk, that there is a risk or there's no risk? We don't know. We know that we use very little epoetins anyway in the adjuvant setting of breast cancer. And as you heard about lymphoma, there's little use of it. And we discussed that the risk of blood transfusion is not to be neglected. And this is what was shown by Dara Span. So Dara, do you want to present your data here?
Thank you very much. Even potentially beneficial to treat patients with EPO, because if we or you or we all would not have EPO at hand, then you know what's left. That's the blood transfusion. A blood transfusion in cancer patients is definitively something we want to avoid. This is one study that I presented, and this is a re-analysis of originally a prospective randomized controlled trial that was performed early in the 90s and also published already in the Lancet at that time. And the question at that time was, is leukoreduced blood actually better for the patients than buffer coat removal? So that was actually the main question at the time. But there were the patients were only randomized to one of these arms at the moment when they needed a transfusion. And now, 15 years later, the authors reanalyzed the data in asking, what is the outcome of those patients who were not transfused versus those who were transfused with one or the other type of RBC. And you can see at 15 years, the chances of having survived is far greater when you did not receive RBCs than with any of these RBCs. And the extra death, this is the most important graph, these are the patients without transfusion, and these are the patients with one and the other type of RBCs transfused. And here it was nearly significantly, here clearly significantly, and the reason for the extra death is cardiovascular for the entire group, which was colon and rectal cancer. In rectal cancer, being transfused also already from the cancer progression nearly was significantly associated with an increased mortality. So then, of course, there was a big discussion about that, whether this was true for other cancer surgical patients as well, and I presented other studies that showed that neck and head and neck cancer surgery, there was similar new data showing that transfusion is clearly associated with a very much compromised outcome in terms of increased mortality, also in pancreatic surgery. And then an interesting question was asked, well, those patients who received RBCs were sicker and they needed an RBC, and I clearly, from a perioperative point of view, I mean, you have already seen or realized that I'm not a specialist in oncology, I'm an anesthesiologist, so I don't understand really the tumor things, but I see in the OR, and there, the transfusions are not given when they're needed, they're given when somebody thinks it's time. And all international analyses show that, the highest risk is, of course, preoperative anemia, and the second highest is the center where you are being operated, and not your biological condition. The question, are there randomized studies in colorectal cancer surgery that use prospective that use like high and low hemoglobin transfusion triggers? I'm not so sure whether that existed, but there are 17 studies on high versus low transfusion triggers that have recently been meta-analyzed by Cochrane Group, and these were on 3,700 patients. And they have found that these the patients randomized to the low transfusion triggers had no adverse outcomes versus those randomized to the high transfusion trigger levels, but had significantly less infections. So they had a true benefit, and overall, the authors of the Cochrane analysis concluded that 7 grams is about good for most everybody. Then the question was, about comorbidities. I will present you an analysis this afternoon on 227,000 patients from the National Safety Quality Improvement Program in the States, showing that slight anemia and RBCs are both, and RBC transfusions are both independent, highly significant factors in increasing mortality and morbidity, and even if you correct for about 70 comorbidities. And Dr. Ludwig then indicated that in another meta-analysis, which I am not really aware of, it had also been shown that blood transfusions are a sign of adverse outcome or are associated with adverse outcome in chemotherapy, in patients on chemotherapy. And then, of course, the question was, what is the mechanism relating those observed mortality and morbidity with RBC transfusions? And there are, a few categories that are potential mode of actions, namely the immunomodulation. There are the studies on patients undergoing renal transplantation, where those being transfused had a better renal outcome in that less rejection. And there is a very important storage lesion. The RBCs change from the first day in the blood bank, so they start lacking of enzymes. I mean, everybody knows 2,3-DPG goes down, other enzymes go down too, all making that the RBCs cannot offload oxygen as well anymore as they did before. They get stiffer and stiffer, and then so that they cannot enter the microcirculation. The older RBCs, the longer stored RBCs, also get quickly lysed once retransfused, and that may really trigger a cascade that in the end becomes pro-inflammatory. And the higher increase of thromboembolic complications in patients receiving RBCs might also be related to the microparticles that are in the RBCs, and the longer they are stored, the more such microparticles which are pro-thrombotic are found in the RBCs. And the question was, you know, in oncology, okay, we have seen the negative effect. Is this seen in other aspects of surgery as well? And the answer is clearly yes. Cardiovascular, trauma, general surgery, and also ICU. There are many studies showing always the same thing. Okay, I think this was it that's the last slide, I guess.
Any questions, comments from all of you about the situation in Hem-Onc and Pere, please? Yeah. Can you just push the button because we are being recorded?
Yes. I've been following the literature on surgery, and I'm very happy to see one item that you didn't emphasize. Part of the story of Rosenberg studies with the colorectal cancer and NCI, they were thought due to the they were not leukocyte depleted, the red blood cells. And we know that white blood cells contaminating red blood cells were immunodepressive. You show that there's no difference from the red blood cells plain and the leukocyte depleted. I think this is a major point, because it clears up the immunosuppressive effect of red blood cells due to the contaminant white blood cells. I just want to make this point.
Yes, that's a very good comment. Actually, there are several other studies from other fields of surgery, including trauma and cardiovascular and cardiac, that come to the same conclusion, namely that leukodepleted blood is not better than the Buffy coat reduced blood. So I would say that leukoreduced blood is maybe a tiny little bit better than the other type of blood, but it's always still not very good for your health in the end. Whether that takes out all immunomodulatory effects, one might expect or not, because the changes on the surface of the RBCs might also, the storage lesion related changes on the membrane surface might also trigger some immunological aspects. And there is also that, the longer the blood is stored, the more such changes occur, and the more the immune system of, these are mainly animal data, of the animals is being suppressed. So that in animal data, in animal studies, the data is relatively clear on that.
Questions, comments?
Maybe one of the problems which we cannot completely exclude is the possibility and risk that patients are transfused with inappropriate red blood cell transfusion units. So a mismatching occurs, and that is a problem because it occurs due to human error, either on the bedside or in the laboratory, and there are estimates that the risk for a fatal outcome is in the order of 1 to 20,000 units transfused until 1 to 100,000 units. So if you consider that in the Western world about 100 million units of blood are transfused yearly, you just by extrapolating this data, you come to a mortality number of about 1,000 people who just die because they receive the wrong blood type. So that is something which should be also mentioned.
You're absolutely right. And, fortunately in our countries we are usually working, this is, as you mentioned, 1 to 18 or 20,000. But what I am proposing, and it's not my personal idea, not at all, but what the literature suggests is that there is, of course, a very tight association between preoperative anemia and adverse outcomes in terms of higher mortality and higher morbidity, and a very strong association between being transfused and having higher mortality and having higher morbidity post-operatively, you know, even in the patients who have received correct, so to speak, RBCs. Now you can say, well, that's all confounded by the, you know, complicated surgery or preoperative problems of the patients. I would say I'm not so sure about that, because, you know, if you are correcting for everything known, and this has been done twice, one in a study from Denmark in hip surgery, where they corrected for 72 confounders, and they found an independent, significant effect of RBC transfusion and increased mortality and morbidity in terms of pneumonia. And in the study that I will show in the afternoon, we have also corrected for 72 potential confounders, and we have been accused of overcorrecting. We have reduced it, but nothing changed, of course. And even if you correct it for everything known, you know, there is a strong signal remaining, and there is no study to the opposite. So, I mean, in the end, we should accept the evidence.
Mario?
I would like you to try to do an educated guess. From all the data you showed, what is the percentage of patients before the year 2000, roughly?
In which analysis?
Of all the data you showed about transfusion.
Just in the only in the reanalysis of the study on colorectal cancer. All the other studies were published 2010 late and 2011, and the study periods were all after 2000. All.
Okay. The reason of the question is that filtering red blood cells at the moment when the blood is drawn is fairly recent. It's after 2000.
Yes, that's true.
So that the filtering before was done at the bedside. That means maybe 2 weeks after the blood was drawn, which is totally useless because the white blood cells that are there have been destroyed and they are present. And by the way, cytomegalovirus disappeared with the bedside filtering. So I think it's reassuring that you say that everything is, or most is behind. The colorectal, I think it's only one sex, right? At a disadvantage, only in women, in the colorectal study.
No, I mean, that would surprise me, but we have to check the paper. I can check the paper in the, at lunchtime.
I think that's the case.
Okay.
Thank you.
And now we are moving to the next presentation, and I think Valeria Santini is the rapporteur on myelodysplastic syndrome, which is a setting of cancer in which patients have no chemotherapy. We are supposed not to give ESAs, and she'll tell us that that's wrong.
It's somehow a little bit easier than for solid tumors, because we are supposed to have sort of homogeneous population. In fact, this is not the case, but the common feature of MDS patient is that they are receiving chronic transfusion or because they have chronic anemia. And the problem may last something like 15 years in the lower risk MDS. So we really face a lot of problems, and we have a lot of evidence now that ESA may in fact influence the natural course of the disease. Sophie Park just addressed the point on when we should start using ESA, not why or if, but when. And she also addressed and stressed the fact that survival is increased by ESA treatment in MDS patients. Now, the evidence suggests at present that if you start on time ESA treatment which is from the GFM, from the French group of MDS French group, 6 months. So if you start before 6 months, you have better response. So if patients have been diagnosed more than 6 months before, you may start, but you have a lower probability to achieve a significant response. A significant response in MDS is measured by IWG criteria, meaning in a transfusion independency for 8 weeks, or an increase of the hemoglobin of 2 grams deciliters. Absence of loss of response is not always correlated with disease progression. This is quite an important point, because we are bound to think that if a patient has responded to ESAs and then loses their response, we are facing a progression of disease. This is not always true. And this is an important point, because we want to understand what we are facing here. What is the marrow what is the event that the marrow is undergoing to? And the following question is strictly related to this. Are we sustaining the normal clone with ESAs? So sometimes we can obtain a very important response. Hemoglobin levels are raised to normal levels also, almost, or even more than normal. And then all of a sudden, the patients stop to respond. Now, is this because the MDS clone has expanded, notwithstanding the treatment with ESA, or because some other factors are intervening? This is a very important question mark. And these are the very interesting data showing that the patients who do respond to ESA have a longer survival. And if you do not respond, or if you lose the response before 1 year after starting treatment, then your survival is significantly shorter than the one of the patients who respond or lose their response afterwards. So I think these data are quite different from what you see in solid tumors. So what are the conclusions? The conclusion are, as I mentioned, that the sooner you start, the best kind of response and the highest rate of response you obtain. Because not only you do obtain response, but your duration of response is longer. And in this view, the time to red blood cell transfusion dependency is, of course, delayed. The evidence shows that in MDS, ESAs may improve overall survival. And then, as I just showed, that the relapse is correlated to a shorter overall survival. And then early failure to respond to ESA is one of the factors that may predict MDS-related mortality. And then we wanted to revise which are the predictor of response to ESAs in MDS. Now, we have, since quite a long time, some clinical predictor of response. These are the low transfusion dependence. You may then consider the WPSS prognostic system. This is a prognostic system based on the morphology, on the WHO classification of MDS, and on the transfusion dependency. It has been revised this year and just published in Hematologica, and instead of transfusion dependency, the level of anemia, which is 9 grams deciliter for men and 8 grams deciliter for women, has been implemented in the scoring system. But we know that a patient who has been receiving transfusion for a long time is the one who's less susceptible to respond to ESAs. The hemoglobin level with which you start your treatment are critical as well. The threshold is not quite defined, so is it better to start with the level above 9 or above 10 gram deciliter? We have to further analyze data in a higher number of patients. Again, here it comes the morphology and the classification of MDS is influenced. If you do not have blast in the marrow, and especially if you do have dyserythropoiesis as a main feature of MDS, you're bound to respond easily. If you have a shorter time from diagnosis to treatment, your rate of response is higher, and we just addressed it. Serum EPO level are also very critical in MDS. Now, which is the threshold again? Some, very many works report the level of 100 units liter, and the 500 unit liters is used by the Nordic group. Now, in between these two counts, of course, is a rather large group of patients. So we could say that 100, the patients who have lower endogenous EPO level than 100, these are the ones who are responding, who have a very high percentage of response, and the ones who are above 500 units are the ones who have a very low percentage of rate of response. Again, these are numbers that should be analyzed thoroughly in the future. Now, we do have now biological predictors of response. There have been a publication last year by, again, the French group showing in vitro that ERK1/2 phosphorylation after ESA stimulation correlates with in vivo response. And my group as well is going to publish a strict correlation of STAT5 phosphorylation in CD71 positive marrow precursor with in vivo response. Then there is the work of the Dutch group, which is the correlation of an abnormal myeloid phenotype, so the myeloblast who express an aberrant phenotype are correlated with a worse response to ESAs. So the IPSS low-risk MDS patient who do have this aberrant phenotype in their myeloblast will not respond to ESA. And then there are a couple of papers correlating gene expression profile of CD34 cells and precursor with the response to ESA in vivo. So our conclusion in this sense were like that. The clinical parameters we do have since quite a long time are not really predicting 100% the response in vivo to ESAs, and they are not sufficient, therefore, to select the patient population. So should we implement these clinical parameters with biological parameters? And how could we apply, how is it feasible to apply this biological parameter today? We should indeed determine their practical utility and see how we could introduce it into everyday practice. Now then we opened up the chapter of quality of life and ESAs. Now, quality of life, as you know, it's very subjective. We have to relate to patient-reported outcome, and we should base our treatment strategy on these, in fact. Differently from oncologic patients, MDS patients do refer dyspnea as a prevalent feature, whereas fatigue is less prevalent in MDS patients. We do know that comorbidities have an independent impact on quality of life. There are very few and not complete studies with comprehensive geriatric assessment in MDS. Studies are just starting now, so frailty is not often measured in this kind of population. Now, as I mentioned before, transfusion need is always present in MDS patients. You have to take into account that 80% of MDS patients are anemic, and in their lifespan they will need transfusion. Transfusions are chronic in MDS and are inversely correlated with quality of life. So the disturbance related to the fact that patient has to come to the hospital, has to be transported there, so there is a caregiver involved, is something that we should always take into account when measuring quality of life in MDS. So as Esther Oliva has addressed, the tools for measuring quality of life in MDS should take into account specific disturbance of this group of patients. We cannot apply the same quality of life tools, assessment tools, that we apply for oncologic patients. Esther has developed a specific MDS quality of life assessment and is going to be validated further. What are the conclusions in this point from point of view of quality of life? Independently from the clinical parameters, we know poor quality of life may determine an urgent treatment. There are not so many studies addressing this quality of life issue in MDS patients. As I mentioned, there is not an appropriate tool, and many quality of life studies in MDS do not use an appropriate tool in our mind. Correction of anemia, of course, and this has been shown in several studies, correlates with improvement in quality of life. And this is all.
Well, thank you again very much. This was a summary which was quite informative, at least for someone who is not in MDS at all. I think I learned a lot in a couple of minutes here. Any comments, questions about this, may I use the word orphan disease?
Almost orphan. It has been adopted. You know, one thing that is quite important, we keep on using ESAs in MDS, but in Germany it's not allowed. For instance, I don't know in which other countries in Europe is not allowed. In France and in Italy, we have a sort of compassionate program, so we can use it. So it's rather funny that we are using these agents since 20 years, even more, and we know that they are working, and they're not approved for MDS. So this is a weird situation.
Right.
Yeah, actually, of course, it's a very good drug for MDS. But as you pointed out, it's not approved for this indication. No. So what we are doing is we are, let's say, bypassing the approval status and use this drug in MDS patients. And probably that should be changed, but I'm not sure what the standpoint of the industry is here. Because you just have to apply, the data are quite clear.
We are running a study, a registration study, which is difficult to run in countries like France and Italy, because we already use the drug, and you have to do a randomized versus placebo study. So we are a little bit in trouble, because we have to tell our patients that we do a randomization when the evidence is such that we can obtain a response with ESAs. Not only, but as I mentioned, in France and in Italy, we can give the drug. So it's even more difficult. That's why we hope that in Germany the enrollment in this study will be easier. But it's a very important study, because as we are facing an economical crisis, it's very probable that in the future we will have difficulties in having these compassionate programs for patients if the drug is not approved.
Okay.
Yes, I was in the... I also learned a lot from the people in that subcommittee. From the point of view, I was like the referee for oncologists, right? There were two very interesting things that we mentioned. One is that in MDS, is dyspnea the relevant problem, not fatigue, which is very interesting. And the reason is because, obviously, in oncology, this comes from the chemotherapy. In myelodysplasia, comes from the disease itself. So it's interesting. They don't talk about fatigue like we constantly talk in oncology. They talk dyspnea. And the second thing you just mentioned recently is a contrary answer to oncology patient where we use transfusions punctually, acutely. They use it chronically for months. So I think for years. For years. For the oncology point of view, those are two most relevant differences.
Indeed, they are, and that. Thank you very much. Long-term use of ESAs, that's certainly something that happens in nephrology, and Antonio Santoro will tell us about that discussion.
Thank you. My task is to summarize the discussion of the nephrology group. On the basis of the commitment, we have only 2 slides. The first one is about the recommendations for the management of anemia in CKD patients. You know that we have 2 different settings of patients in nephrology. One is the patients with chronic kidney disease, but not on chronic dialysis, but in conservative treatment before initiating the therapy. And the other is the setting of patients on chronic dialysis. In dialysis patients, the therapy with people, the target are a little bit different because we have the interference of dialysis. You know that during the dialysis session, during the dialysis procedure, we have to remove the plasma water of the patients. So we can have an increase in the hematocrit of the patient. So patients starting dialysis with an hematocrit of 30% may increase the hematocrit throughout the dialysis session. Patients starting with the level of hemoglobin about 12 may have, at the end of dialysis session, 14 milligrams deciliter of erythropoietin. So this is the recommendation of our group about the CKD patients with anemia. The first one is in presence of anemia related to the absolute or relative hypodeficit. We can exclude other causes of the anemia, and we have to define that this anemia is related to the presence of a chronic kidney disease. They initiate specific therapy when the hemoglobin is less than 11 grams per deciliter. But we have the need to individualize the target of the hemoglobin. We have to tailor the target probably in the patients. Because in guidelines, in US guidelines, but European guidelines, the targets are fixed, and the target are between 10 to 12 grams to deciliter. The other recommendation is to optimize the ESA therapy, but before we have to check, but before the optimization of the ESA therapy, we have to check the iron balance, because in presence of the iron deficiency, we need the iron supplementation, because in some patients, only with the iron supplementation, intravenous or orally, we can have the normalization or the increase in the hemoglobin level. And lastly, patients hyperresponsive to ESA therapy should be systematically investigate to other causes, because we can have other causes of less sensitivity to EPO, increase in PTH, inadequacy of dialysis, the presence of thyroid dysfunction, or the presence of inflammation, infection, and this may induce hyperresponsivity to the ESA therapy. But in nephrology, there are many open questions. These are something of this question. The first is the target hemoglobin level, as I said, because the risk-benefit is the same in all the setting of the patients, or we have to change the target in some subgroups and setting of patients. It has for patients with heart failure or patients with other kind of anemia, we have to check and we have to maintain another target of the hemoglobin. The second point, the second open question is when to have to start the treatment. And the target, we have to start very early, or we can have a late target, and we start when the hemoglobin reaches 10 grams or 11 grams per deciliter. The other is the need, in some cases, of the algorithm for or models for the delivery of intravenous iron or ESA doses or ESA dosage. And we have models and algorithms to obtain these to obtain the optimization of the dosing in the dialysis patient. And the other is the problems of the benefit and harms of the high versus a low fixed ESA dose. One of the problems in dialysis or in CKD patients is that we have many studies demonstrating that if we have an increase in the levels of the hemoglobin, we normalize the level of the hemoglobin, we can have an increase in the cardiovascular events of the patient, we can increase the mortality of the patient. And one of the debates that we have is that this is due to the high target of the hemoglobin, or this is due to the use of high dosage of the hemoglobin in this case. Because in general, we use high dose of the hemoglobin in patients with a lot of comorbidity, and I said earlier, patients with resistance to the action of these. And lastly, the last point, the open question, how we can monitoring the hemoglobin and the target and the therapy, but not only the ESA therapy, but also the iron therapy. We have a large debate if it's better intravenous iron or orally iron, but this is one of the debate in nephrology. At this point, I think that Professor McDougall, just arrived, may add something about that, because he's the leader of this group, but he's...
Okay, thank you very much. I mean, I will come back to some of the issues when we discuss the updated guidelines, like the international anemia guidelines, which are not yet published, but are now closed to further public consultation. So, and I agree. I agree with your guidelines. I'm very concerned that the US, particularly, are becoming very aggressive with. Are very conservative with anemia management. So there, as you know, the latest guidelines are suggesting that you can let the patient drift down to 9 grams per deciliter. I will show this afternoon. The absolute maximum they're recommending is 11.5 grams per deciliter. So these are guidelines that will be published in the middle of next year. They're international guidelines, and I will come back to them in later. But I would tend to agree with you. I think that things have gone too far with some of the evidence base, and I much prefer the ones that your group has suggested. I'm very sorry I did not manage to get here last night due to the fog around Heathrow, but thank you.
What do you think about the iron? The iron, intravenous or oral?
Well, I use exclusively intravenous iron. I never use oral. The question is if somebody has a fairly well-preserved renal function, their hepcidin levels are probably not too bad, and they might absorb some oral iron. My personal experience is that the side effect profile with oral iron is very high, and the side effects with intravenous iron are very low, and then you have to discuss whether there are other safety issues with intravenous iron which are not yet proven. But I never use oral iron in CKD patients at all. And
intravenous, you don't have the risk of the overload of iron?
No.
How do you check
So we can use the ferritin. I mean, if the ferritin stays below 1,000 or even 1,200, we know that these patients are not overloaded.
Thank you.
You know that...
Can you just talk to the microphone because we are being recorded?
For MDS, we have to give iron sometimes when there is small evidence that if you are below 80 microgram, then you lose the response to ESAs. Now, we are said that we have to give IV iron, but I never see the difference. For an MDS patient, is there any background for that? Why cannot I give oral iron if the absorption is fine? What is the difference?
I think the question is for
I mean, so the hepcidin biology has taught us a lot about kidney uremia, and we know that in most kidney patients, hepcidin is hugely upregulated. I imagine, I'm not aware of the literature on measuring hepcidin activity in MDS. You do it?
That last paper was
I am so sorry I don't keep up with the MDS literature. It's hard enough to keep up with the kidney literature. So, no, it's okay. So the hepcidin levels are low in MDS?
No. Let's say that they are not correlating with ferritin.
Okay.
And in one subgroup of MDS, they are higher than expected.
Okay.
But usually, and let's say that in refractory anemia with ring sideroblast, then hepcidin is low. But
Okay.
otherwise, no. And this is why I'm always asking myself, is this the same situation? Why should I give IV? For us, it's very unpractical to give IV iron.
I mean, I really cannot comment on whether oral iron would work in MDS. I think, I suppose it could. It just, we are very well set up. We have 3 IV iron clinics a week run by nurses, so it's very easy for us to give IV iron, which is one of the reasons I use this. And it's very interesting you say the hepcidin does not correlate with ferritin, because there are a huge number of papers now in the kidney literature.
Not always. I mean,
Yeah,
it's
okay.
you know, there are so many dysregulation of erythropoiesis in MDS that you cannot extrapolate the
Sure.
same situation as in.
Exactly. So you have dyserythropoiesis, whereas we just usually have just reduced erythropoiesis. And it always, the hepcidin levels almost invariably, I don't think there's been any exception, always correlates with the ferritin level in the literature that I've seen.
Could you quickly comment on the new drugs that are around the corner? What was the discussion about that?
Yes, the opinion of the group that we don't need new drugs because we have enough ESA now. We need very cheap drugs, but probably we don't need new drugs, at least now in CKD patients.
Regarding the oral iron, that is something which amazes me because we don't use it. You could use an iron resorption test and see whether in this very individual patient iron resorption is still active. And that is a simple test.
Yeah, but this is what we do.
You test your patients.
Yes.
You do an iron.
I mean, an iron charge, and then you measure.
Yes, you measure
free
after
iron?
you measure
Yes.
after 2 and 4 hours.
Yes, this is what I do usually.
Okay, and then probably, maybe you can. I wonder what you can explain how you are doing it and how many of your patients with MDS have an impaired iron resorption. How many?
This I will not tell you because I don't know the rate. But this is an interesting thing to check. But usually, when before starting oral iron therapy, I always do an absorption test. Yeah.
Can I just ask you about the oral iron? So you're using as first line ferrous sulfate?
Yes.
The iron salt. And so the second question is really do we have any clue as to the incidence of gastrointestinal side effects in the MDS population? Because in the general population it's 30%, and similarly in
Now you see, as they are old patients, most of them do have side effects.
Okay, well, thank you very much, Ken. And sorry, Mario. Yeah, there's a question of Mario Di Cato. I had missed it.
No, it's not a question, it's a comment. I was the non-nephrologist in the group, and I got a crash course in nephrology. It was great. It was absolutely great. But the problems are a little bit different, especially regarding iron, than we have in oncology, because in oncology you're treating non-curable patients, so it's a completely different setup. And the treatment with ESA and iron in that setting is much shorter, but they have the model of chronic treatment for ESAs and for iron, which is extremely different and interesting. So I'm very happy. I was very reluctant to go into the group, but I'm very happy I went there. It was profitable.
We always learn from other areas.